a privilege to welcome Dr. James Lemos presenting on a topic that is certainly very of interest at the Heart Institute and certainly Dr. Lemos' clinical interest as well. Dr. Lemos is a University of Texas Board of Regents Distinguished Teaching Professor and the chair of cardiology at UT Southwestern Medical Center. He graduated from Harvard Medical School and completed internal residency at UT Southwestern, where he was chief resident, did another fellowship in cardiovascular medicine, and served as faculty at the Brigham for a number of years before going back to UT Southwestern in 2000. He's the current chief of cardiology and has held numerous positions of importance, including the STEMI Guideline Committee, chair of the Research and Publications Committee for the NCDR Action GWTG Registry, and most interestingly, most novel is he's the PI for AJ's COVID-19 cardiovascular disease registry, which is really very relevant and touched a lot of patients so far and will into the future. He is executive editor for CIRC and has previously served on multiple editorial boards, including JACC, AJC, and AHJ. Primary interest is biomarkers, early risk detection, and is currently the PI for the Dallas Heart Study. He's had numerous publications, hard to describe in such a short introduction, but certainly very privileged to have Dr. Lemos with us today. Yeah.
Thanks, Dr. Chan, and thanks to you all for just a wonderful visit and great hospitality. And I'm really impressed. We were just talking. Really, this place is a model for integration across disciplines that reflect research and clinical medicine and cardiovascular surgery and other specialties that we really can emulate. And what I'd like to do over the next 45 minutes or so is sort of journey through my research journey in some ways in cardiovascular biomarkers as we started 20 years ago with great hope and share some of the struggles and how I think we may be emerging on the back end with some promise with regard to how to capitalize on the promise of precision medicine. I've got a number of disclosures related to work I do either in the biomarker diagnostic field or DSMBs that have therapeutics that might be related to cardiovascular prevention. So our US president in 2015, President Obama announced with great fanfare the Precision Medicine Initiative, saying that recognizing that doctors had always recognized the uniqueness of individual patients, but raised the question of what if we had simple tools that could individualize therapies with a drop of blood or other simple tools. This came with a funding prerogative and great fanfare 8 years ago. And I think it's worth sort of taking stock as to whether we've made much progress in the cardiovascular space following this initiative. And if you think about what we're looking for are tools, diagnostic tools, clinical tools that provide direct insight into the underlying pathophysiology of the diseases that you and I treat. And that information about pathophysiology can be exploited to make specific therapeutic treatment recommendations. And we've got some great examples. The best example in the ED is the 12-lead EKG showing ST segment elevation, where we've got a tool that provides certainty in many ways about the underlying pathophysiology. When you see ST elevation, you have complete occlusion of an epicardial coronary artery and transmural ischemia, and it leads to an immediate therapeutic response, immediate reperfusion therapy. Also, importantly, in the absence of this finding, the pathophysiology is more heterogeneous, but includes subtotal vessel occlusion, distal embolization, subendocardial ischemia. But equally important, not only was fibrinolytic therapy in the early days not shown to be beneficial, it was actually shown to be harmful. So you've got a tool that tells us what's going on sort of beneath the hood from a pathophysiology standpoint for the patient that we exploit to make go, no-go decisions. A great example of precision medicine that we don't think about. But there are precious few of these examples for us. What we typically do is apply average treatment effects from randomized controlled trials and or guideline recommendations treating most patients the same. We're doctors and we individualize care all the time, but we do it based on our intuitive clinical judgment. based on the clinical course, how the patient responds to our initial therapies, and reevaluate, but it's not largely evidence-based in terms of how we're guiding these approaches. When we do use tools to individualize medicine, they're relatively crude themselves. Think about some of the tools that we use daily, the pooled cohort equations in the US for initiation of lipid-lowering therapy and hypertension, the CHADS-2 VAS score, a daily acronym that's used in clinical medicine, but frankly, performs very poorly when evaluated as a predictive metric. And so we use these crude tools to apply therapies to those at the greatest absolute risk to maximize either the risk benefit or the cost benefit. But that's a mile away from where we hope to be, which is to use pathophysiology to guide our treatments. We published about 4 years ago, sort of a thought piece in Circulation where we highlighted really the need for tools that could help make some of these decisions. If you think about a person that's recovering in your hospital after a non-ST elevation myocardial infarction, and they're on the usual rally pack of therapies that include aspirin, a P2Y12 inhibitor, statin, RAS inhibitor, beta blocker. Within the last 5 to 10 years, there's been demonstration from well-conducted randomized controlled trials of add-on therapies to the usual guideline-based medical therapies that might include additional therapies that address coagulation, whether that be more potent or longer duration P2Y12 inhibitor or even low-dose rivaroxaban in the antiplatelet and anticoagulant field. Multiple new therapeutics targeting metabolism, SGLT2 inhibitors, GLP-1 agonists, and combination drugs. Anti-inflammatory medications with the publication of data demonstrating benefits of canakinumab, emerging suggestions that colchicine may be beneficial, and then tremendous efforts in the lipoprotein arena, going beyond just LDL cholesterol, considering triglycerides now, LP(a). And so when faced with what are invariably very expensive choices in each of these spaces, you might consider a secondary prevention patient now and think that there might be evidence to support any one or all of 5 or 6 new therapies beyond the 5 therapies we give everyone. So there's got to be some sort of objective basis for making these decisions other than that's what we do here, or this is my favorite, or this is the one that the insurance company covers. But we're going to need to understand which of the unique components of pathophysiology are present to make educated decisions for individual patients. And we, at this time, just guessed at some of the tools that people might use, and they weren't all biomarkers. Some of them might be biomarkers, some might be clinical responses, some might be demographic features. But the real point of this was to highlight that we don't have those tools. We have these therapies, they're expensive, but we don't have the tools that we need to help guide those decisions. And, we've struggled since in cardiovascular medicine, and in particular, when you consider and contrast what's happened in cancer therapy. Our risk assessment tools are crude, and despite the fact that they're easy to use and we use them all the time, their performance is frankly marginal. They're developed for composite endpoints that in these different endpoints like stroke and myocardial infarction may reflect very different pathophysiology and more heterogeneous pathophysiology. The other issue is that the precision tools that we have don't, in many cases, don't capture the disease pathophysiology we're thinking about. We obviously, with a few exceptions, have very limited ability to get tissue from the organs of interest that we have. That's a major component of what puts us at a disadvantage relative to the oncologists. Where we can measure the metabolome, the proteome, it may be argued that what we're measuring doesn't reflect the target tissues of interest. We can measure things in the blood, but they may not reflect what we're actually interested in. And let me show this example. I certainly started my career in sort of large-scale biomarker development in the sort of the pre-somologic era with measuring many candidate biomarkers, thinking certainly that with the right biomarkers that have been demonstrated in the laboratory to be causally related to atherosclerosis, of course we would develop biomarker panels that reflected atherosclerosis burden, the composition of plaque, and the propensity of plaque to rupture and cause myocardial infarction. But that's really failed quite miserably, frankly, in terms of our ability to get disease-specific non-imaging biomarkers for atherosclerosis. And fundamentally, Peter Libby brought this point to me. He said, it's not going to happen because it's a signal to noise problem. You're trying to capture in the circulating proteome features related to tiny tissue sources. The atherosclerotic plaque and the components of the plaque simply won't release sufficient quantities of the biomarkers we're interested in to be distinguishable from background noise. Now this isn't completely done, but I'd say that the ability to get plaque markers from the bloodstream seems limited. And so what we're left with really are biomarkers that reflect the effluent from large organs, the liver, obviously with lipoproteins and inflammatory markers, but also the myocardium. And I'll come back to that. And as I've struggled really with many failed experiments in this space, I've become, as you get older, you get more pragmatic. I've become more pragmatic with thinking about what can we measure that reflects the organ or disease we're interested in, and can we exploit that even if we can't get the target tissues we're interested in. So rather than, and what I'll say is that largely the precision medicine goals in cardiovascular medicine have not been met with biomarkers. They haven't been met yet with genetics, but I think we can take baby steps towards a precision medicine goal by doing what we already do better, and that's improving and refining risk assessment. And let me tell you a little bit more about that idea. So, current U.S. prevention guidelines and Canadian guidelines also incorporate risk assessment front and center into major clinical decisions in cardiovascular prevention. I'll spend most of the rest of the time talking about prevention and population health. But where in the cholesterol guidelines, risk assessment is front and center in the decision-making for allocation of statin and other lipid-lowering therapies. And so this is a quantitative assessment of individual risk that's based on multivariable models of traditional risk factors. And if you're above a certain 10-year risk threshold, generally you're recommended for statin. And if you're below, you're recommended for lifestyle changes with some acknowledgement that there are risk modifiers that, including some biomarkers that may push you one way or the other. But the key point is that we're already using risk assessment to make some of the more important decisions that we're doing. What's less recognized in US guidelines is that this is also embedded in the decision for medical therapy for hypertension. So the new US guidelines classify stage 1 hypertension, which is a massive proportion of the population in North America, as those with blood pressures 130 to 139 over 80 to 89. But the decision on whether or not to initiate drug therapy versus lifestyle modification first is based, I locked up here, didn't I? To ask me to restart PowerPoint?
Close the program and we'll share it again.
Okay. There we go. Back. It's back.
It's back?
Yep, I'm back. It's fine. What's less appreciated is that this actuarial risk assessment is embedded in the decision to initiate drug therapy. So people who have a 10-year risk above 10% for ASCVD events get treated with drugs, and the rest get treated with medical therapy. And the question really is can we do better? Because as I've mentioned, there are challenges with what we're currently doing for risk assessment. And the first issue is that the traditional risk factor models that we use to make these important decisions just don't work well enough. These are older data from the old Framingham risk score, highlighting that the majority, this is US data, the majority of the US population falls into low risk, shown in blue, with smaller proportions in intermediate and high risk. If you look at where the events occur, the high risk individuals, these scores do work, they just don't work well enough. The high risk individuals have the highest proportion of events, but if you added up the number of events that occur in the combined intermediate and low risk populations, they exceed the high risk population. And this low risk group is a group that would not be recommended for preventive therapies, hypertensive therapy if they have stage 1 hypertension, or lipid lowering therapy. And I'll make the case that anybody who is identified as low risk who goes on to have an event and was not offered preventive therapy represents both a failure of risk prediction and a failure of prevention. So the question is, can we improve risk assessment to reduce these missed events? The other issue with the actuarial scores is that, as I mentioned, the performance is moderate at best. If you look at the pooled cohort equations in the discovery data sets and the replication data sets, the C statistic, which is basically the ability to discriminate future events from non-events, is moderate at best, with AUCs or C statistics in the 0.6 to 0.7 range. So very unimpressive performance overall. And when you go beyond it, maybe arguably an issue that I thought was no big deal when the papers were published is the issue of calibration. Calibration is the ability of these tools to match expected events with actual events. And what was seen very early is that these tools overestimated risk at the low end, so that individuals that were perceived to be at low risk, individuals at the lower end had an exaggerated expected risk. And I thought at the time, I'm fine with that, because when these were rolled out, worst case scenario, if you're overestimating risk in low risk people, is you give more people in the population statins. But now we're talking about augmenting blood pressure therapy and putting people on drugs that may have side effects. We're entering an era where we have multiple options for lipid lowering, some of which will be really expensive, and they will be allocated on the basis of future risk. So it becomes increasingly important in an era where we go well beyond statin therapy for prevention, that our ability to be to not misclassify low risk individuals and to have precise calibration is increasingly important. The second issue with what we're currently doing is that the focus on ASCVD is too narrow. We're in the midst of heart failure and atrial fibrillation epidemics, in part because we're victims of our own success. Incident ASCVD is lower due to better prevention in the population, and people who have ASCVD are living longer and developing, and they live longer with existing structural heart disease. The epidemiology suggests that heart failure is already more common in elders than coronary disease and stroke, and the estimates are 25% increase in prevalence over the next 20 years. And the story is the same for atrial fibrillation, with a lifetime risk of a quarter and prevalence numbers that are staggering over the next couple of decades as the population ages with cardiovascular disease. So risk prediction and prevention efforts that fail to consider preventing heart failure and atrial fibrillation are incomplete. And so the question is, can we do better? Can we develop more precise prevention and population health tools to go from, if we're in the office, to identify among the heterogeneous individuals that we see for a prevention visit, which ones should be treated and which drugs they should be treated with? And also, can we do it at the same population health level? And I'd say you all in Canada are really the incubator for these kind of approaches, because you think about population health all the time, but the same concepts exist. Can we use some of the same enhanced risk assessment tools to decide who in the population gets usual care and who gets referred to Ottawa for more specialized prevention care, whether that be in person or virtual? And I think we can do better there. And the candidates to do better include genetics, biomarkers, imaging. I won't talk about genetics. I'm not a geneticist. I will say that the progress of genetics for risk prediction has been much slower than anticipated. I think we're finally getting to a point where there may be an actionable clinical risk prediction tool with polygenic risk scores, but that's been challenging to apply to multi-ethnic populations. When you look critically at how it performs relative to imaging and biomarkers, it's not as great as advertised. So even the polygenic risk scores look like they only really move the needle with prediction at the very highest distribution of the polygenic risk scores. But I'll talk about biomarkers, the area mostly, which is the area that I've been working in. I'll start with CRP, the prototype inflammatory marker. There is no question that inflammation is central to the pathogenesis of atherosclerosis and its complications, or that CRP is an interesting marker to consider. This is from the back of the room or online, meant to be just a conceptual slide. You don't have to look at the details, but this is from the Dinesh meta-analysis of 54 studies, 160,000 individuals, almost 28,000 outcomes. And from the back of the room, what you can see is the consistency of the association that, these studies largely confirm higher CRP associates with higher rates of ASCVD events. So this is shown per tripling of CRP. The challenge with CRP is that the magnitude of the association is modest. And so typically for a tripling in CRP, you get an adjusted hazard for events of about 1.3, which candidly is not enough to move the needle. It doesn't move measures of discrimination like the AUC. And most importantly, it doesn't lead to clinically relevant risk reclassification, because what you're trying to do in the office when you see somebody that you think has a 3 or 4% 10-year risk is identify tools that might move them sufficiently high that they merit treatment or enhanced observation, or if on the border, that it's a powerful enough tool that moves them low enough that you can defer treatment. And what you're going to need are tools that have much stronger adjusted hazards than 1.3. The thought is that you'll need things that are at least 2 and arguably higher to move the needle. And it makes sense intuitively, right? If you're looking at low risk individuals, you need to be able to move the needle to put them in a treat category. And so CRP as a single standalone marker just isn't robust enough. But even if it wasn't, one could make the case, well, if it is relevant from a pathophysiology standpoint to driving therapies, meaning is there an interaction that it might still be useful even if it's not a strong risk predictor. There was lots of hope for this when in the early statin era. This is data from Jupiter, which enrolled only individuals with CRP above 2 and randomized them to rosuvastatin or placebo. But if there was something special about the relationship between CRP and the benefit of statin therapy, one would expect that the relative benefit of statin therapy would increase as, I think I lost my point. Let me do this again, just so people online could see. One would expect the relative hazards to increase at higher CRP levels. That's not seen here. What's seen is similar benefit of rosuvastatin across tertiles of CRP in men and women, suggesting there's sort of no magic interaction. I will say, and I'll come back to this, that the absolute benefit, because higher CRP is associated with absolute risk, is greater at high CRP. So there is some ability to improve the NNT, if you will, for statin therapy with higher CRP. We'll come back to that concept because we had great hopes that we would find biomarkers that led to qualitative interactions, meaning the therapy fundamentally worked better in people with high biomarkers. We've not found many of those that exist, and when we find them, they haven't replicated. So we end up coming back to this concept of quantitative interaction and not qualitative interaction, meaning can you identify higher risk people that will have higher absolute benefit? So if CRP is a modest tool, what about biomarkers that are more directly reflective of cardiovascular pathophysiology? CRP is obviously an acute phase reactant in the liver. And here, we in many groups have done a lot of work with natriuretic peptides. These are cardiac hormones that provide lots of insight into cardiovascular health. And over a decade ago, we published data from the Dallas Heart Study showing these are MRI measurements of left ventricular hypertrophy or left ventricular systolic dysfunction. Again, this concept of expanding screening and prediction and prevention beyond just ASCVD. And you can see, not surprisingly, striking associations with underlying structural heart disease across higher levels of NT-proBNP. And so and we also found, surprisingly, actually at the time, that there was a significant but modest association with coronary calcium, marker of atherosclerosis, that was independent of all of the known determinants of natriuretic peptides. So at face value, an attractive screening test, it's strongly associated with structural myocardial disease and moderately associated with atherosclerosis. And in fact, when people have looked at the ability of NT-proBNP as a risk predictor in the population, it performs quite well. It's not used by many of us, but it performs quite well. So HDL obviously is a strong risk marker included in the pooled cohort equations because of this. If you look at the relationship, this is a meta-analysis of 33 studies, 100,000 individuals, including our Dallas Heart study and other population-based studies. You can see that the relationship is logarithmic with lower HDL and ASCVD, but surprisingly for ASCVD, the NT-proBNP relationship is almost identical. And so NT-proBNP is as good a marker for ASCVD as HDL. But when you look at incident heart failure, not surprisingly, the story is remarkable. So NT-proBNP is a good marker for ASCVD and a great marker for future heart failure risk. And if you were to compare this with CRP, it's not even a contest. Even for ASCVD, it's much stronger NT-proBNP than CRP, and for heart failure, it dominates. We've been most interested in biomarkers of cardiac injury, and have been working in this space for well over a decade. Soon after the high sensitivity troponins were developed for research purposes, we sort of launched simultaneous studies in 3 of the large US cohorts. Our Dallas Heart study, which is a younger population of multi-ethnic, the Cardiovascular Health study, which is a older US population, 65 and older, with the important addition that there was, and I'll come back to this, there was a second blood sampling done 2 years later. And then the largest of these studies was the atherosclerosis risk in communities, a biracial community of about 10,000 adults that were middle-aged. And about a quarter of our DHS population had a detectable troponin when measured with the high sensitivity assay. This was a troponin of 3 nanogram per liter, which was at the time a remarkable finding, and in and of itself, that individuals were with no symptoms in the population were sort of walking around with troponin levels that were measurable. And if you looked in the older populations, CHS and ERIC, it was about 2/3. So this test that we've been using for many years to diagnose myocardial infarction, turns out if you have a sensitive assay, you can detect levels in large numbers of the population, and it's age dependent. It turns out it's very sex dependent. And the obvious question that came up is, what does it mean when you have detectable troponin in ambulatory life? And we term this chronic myocardial injury, and people who have not acute level rise, but chronic baseline levels that are above the detectable range. And we modeled this in the Dallas Heart study. We found male sex, older age, diabetes, low GFR, not surprising for all of you who use troponin in the hospital, were associated with higher levels of troponin in daily living. But what was interesting was the structural phenotype. So every measure of cardiac structural abnormalities, LV mass, wall thickness, chamber dilation, all associated strongly with troponin. And equally important is what didn't. All of the vascular measurements. So the DHS is a general population sample, so some of the people have prior disease. So prior MI, angina, and coronary calcium did not independently associate with troponin. And so this test that we've been measuring to diagnose heart attacks is not a vascular marker, it's a muscle marker, and it just happens to go up because of it goes up because of problems in the vasculature, but it's a muscle marker. And so this reoriented us to thinking about troponin and chronic injury as a fundamentally a muscle issue and not a vascular issue. And then we pursued whether this, given these phenotypes that we saw with the deep phenotyping in the Dallas Heart study, what this might mean for clinical risk prediction. So again, the Dallas Heart study is not a disease population. This reflects Dallas County adults statistically circa 2000. We followed in the initial paper these individuals for 6 years, and we divided them into those with undetectable troponin. That was about 3/4 shown here. The group in category 5 here had levels that would have been above the detection range of the standard assay, and we divided everybody else in between. And you can see that this chronic injury marker that associated with structural findings on the MRIs strongly stratified risk of mortality. And this was striking, really. You've got people in the general population with this 2% had a 6-year mortality of almost 30%. ERIC was the largest of these studies and had sufficient numbers of the individual endpoints to tease out what exactly it was that the high sensitivity troponin T was predicting. This is what's called a cumulative distribution plot. So this is adjusted hazards across sequentially higher levels of troponin. And what you can see is that there's strong associations, adjusted hazards up to 4 at the higher levels for coronary disease. It's more robust for all-cause mortality and particularly strong for incident heart failure. I will point out that for coronary disease, even though it's a stronger predictor of heart failure than coronary disease events, it's still, troponin still notably outperforms high sensitivity CRP, even for coronary disease. So this looks to be an interesting marker for predominantly for heart failure, but also for fatal cardiovascular disease and coronary disease. And the obvious next question is this a modifiable phenotype, this chronic injury? And that's and so in the cardiovascular health study, I mentioned they had a second blood measurement done a couple of years later. And so stratified here in groups are the baseline levels. And you can see that cardiovascular death goes up as the baseline levels go up. But shown in blue are people whose levels increased by 50% or more. In red are those individuals whose levels fell by 50% or more. In green are those that stayed the same. And so what you can see is that regardless of where you started, if your levels increased, your risk for death increases. If they fell, your risk for death fell. The picture is exactly the same for incident heart failure, and it's all independent of everything else we know that associates with death and heart failure. But an important finding, because it suggests the potential that this phenotype is potentially modifiable, so that if we can find therapies that reduce high sensitivity troponin in the population, or at least prevent increases over time, that we might modify the future trajectory of heart failure and cardiovascular disease in the population. This may be a tool to guide prevention or population health, in much in the same way BNP could be used for that. So what we've done since these publications is try to tease out factors that may lead to more favorable trajectories of troponin over time. Most of our work has been observational. I'll come back to some randomized data. And so they're limited, obviously, by all the limitations of observational work that residual confounding and the difficulty assessing causation. But in general, studies, they're not all perfectly consistent, but in general, studies suggest that higher levels of physical activity and fitness and lower time spent in sedentary behaviors lead to more favorable trajectories for troponin. Long-term lower hemoglobin A1C trajectories and better blood pressure control associate with lower troponin. And then certain therapies are emerging as potentially modifying cardiac injury, including the SGLT2 inhibitors. Another way we've taken sort of baby steps towards precision medicine beyond actuarial risk assessment is to try to enhance known phenotypes by layering biomarkers on top of them. I'll give you one example of this. This example is the characterization of a phenotype that we've termed malignant left ventricular hypertrophy. LVH is known for decades to be associated with future risk of ASCVD and particularly heart failure. We looked at the interactions between MRI and then in other studies, echo and EKG LVH with the biomarkers we've been talking about, high sensitivity troponin and NT-proBNP, and heart failure outcomes in the population. And what we found consistently is that about half of the people who have LVH by any measure have normal levels of biomarkers, and about half of them have abnormal levels of the biomarkers. Those individuals with LVH who have normal levels of biomarkers have risks of cardiovascular death and heart failure that are indistinguishable from people without LVH, where those individuals that have LVH with abnormal biomarkers, and in this case it's troponin, in other studies it's been troponin or NT-proBNP, have a markedly increased risk of incident heart failure. In this study, over 20%. And if you look across multiple studies, we've published across 4 cohorts, you can see that the overall population prevalence of this phenotype, malignant LVH, is between 4 and 7%. The LV, that's about half of the overall LVH prevalence. And if you look at the adjusted risk for heart failure, it ranges between 4 and 7. So really very powerful associations of this phenotype, structural heart disease with biomarkers that reflect the consequences of structural heart disease. As I mentioned, what are we looking for tools that might move the needle with risk prediction? We want biomarkers or tools that have large adjusted hazards, because that changes your thinking when you're seeing the patient in the office. If you see somebody on this basis who you think, somebody with hypertension in the office, and you see this phenotype and their predicted risk is 4 or 7 times higher, that leads potentially to a different approach to that person in terms of things that you might do to prevent progression. One of the big stories here has been that this phenotype is remarkably overrepresented in Black adults compared to white adults. That's both and this is the prevalence of malignant LVH across 4 cohort studies in Black men, Black women, white men, and white women. And I'll point out that it's about 3 times higher in Black than white adults. But interestingly and really scary is that the prevalence is higher in Black women than white men. And what's not often appreciated in the US cohorts, at least, is that the rate of incident heart failure now is higher in Black women than white men. So this is what we call an intermediate phenotype. This is malignant LVH is in the pathway from hypertension to eventual heart failure. And the question is, are we identifying using a precision-like tool, a phenotype that we can modify? And we don't know a lot about this yet because we've just started thinking about this, but we do have data from this SPRINT trial led by Jarrett Berry. SPRINT, and I'll come back to talk about this a little bit later, but SPRINT is a large RCT that tested more intensive blood pressure goals. And what Jarrett did is he looked at the effect of the intensive blood pressure lowering, both on the conversion from hypertension to this malignant phenotype, but then mapping onto heart failure events, and found that the more aggressive blood pressure target led to lower incidence, new cases of malignant LVH, and led to, in that group with malignant LVH, lower rates of heart failure. So not rocket science, this would probably fit with what everybody thinks would happen, but you may if you take people with hypertension and treat them more aggressively, you may prevent malignant LVH. And if you detect malignant LVH and tighten the blood pressure control, you may mitigate the downstream consequences. And if you do that, arguably that may address in some ways racial disparities in heart failure that may be captured by this intermediate phenotype. So take home on biomarkers, CRP arguably doesn't provide enough information as a standalone predictor or tool to select candidates for prevention. It's consistent, modest associations with risk. I didn't show these data. It's not in the causal pathway. I think that NT-proBNP and high sensitivity troponin are more promising. They predict heart failure and fatal cardiovascular disease more than ASCVD, and they can help stratify LVH into benign and malignant phenotypes. I didn't talk about this, but aptamer-based arrays will clearly open the door for large-scale discovery. They already have, but I will say that to date, the clinically actionable biomarkers have not emerged from these large-scale discovery tools, although it's still very early in that natural history, and I'm still optimistic that there will be some that emerge. Let me talk just briefly about imaging, and then I'll think about how we might put it together. This is our data from coronary calcium. There are obviously many other pieces of data that look exactly the same. In terms of tests that move the needle, coronary calcium for coronary disease risk prediction is exactly that, where you see very large separation between those with try to get the pointer back on, but of 0 have very low event rates and very striking step up across higher calcium scores. And this magnitude of association, because the adjusted hazards are large, leads to meaningful improvement in the C statistic, or the area under the RC curve. And when you look at measures of risk classification, the metric that epidemiologists use is called the net reclassification improvement, or net reclassification index. And this is applying that only to intermediate risk people. So this shows the proportion of individuals correctly reclassified to lower or higher risk categories by adding this test. And if you look at the NRI for calcium scanning, it is much more robust than any other imaging test, IMT, ABI, flow-mediated dilation, which don't perform nearly as well. Much stronger than C-reactive protein. Interestingly, in the one study that measured it, NT-proBNP is sort of at least potentially in the same ballpark as calcium scanning. This is sort of handicapping the various contenders for reclassifying intermediate risk individuals. So we had funding, actually, interestingly, from NASA, who has a lot of interest in actuarial risk assessment, because their next big thing is at least considering flying middle-aged adults to Mars, which is a three-year mission. And short of a mission-related catastrophe, the biggest threat is a cardiovascular event in space. And so they're keenly interested in identifying and mitigating cardiovascular risks related to long-duration spaceflight. And so what we did with funding from this is we looked at data from our Dallas Heart study in Mesa, and we looked at the baseline examination where we did a clinical evaluation for risk factors, a 12-lead EKG for LVH, which, as I've mentioned, is a powerful tool. We looked at the blood markers we've talked about, CRP, NT-proBNP, troponin, and the CT scan for coronary calcium. And then we followed these individuals over 10 years, and we looked at a global cardiovascular disease endpoint. And as I mentioned, this is what I think our patients want that come and see us in the prevention office. They want to know, it's certainly what NASA needs, but our patients are interested not just in freedom from heart attack or stroke. They want freedom from heart failure and AFib as well. They want freedom from any adverse cardiovascular event. And we've termed that endpoint global cardiovascular disease. I will acknowledge, some of you in the back are saying that's as far away from precision medicine as you can. It is. It's sort of, by lumping all that together, we are arguably moving away from precision medicine. In part, it's pragmatic because the biomarkers don't distinguish well between the individual endpoints, and in part, I think it does reflect, at least on a population health level, some of what we need to do. Now, these populations were somewhat different. The DHS was in the mid-40s, more than half women. Half of the population in DHS is African American, and Mesa was a little bit older, but still had a quarter African American. And we sort of created pre-specified abnormal thresholds for each of these tests. EKG LVH was prevalent about 10% in DHS, and you can see the prevalence of the other risk factors. CRP was by far the most prevalent abnormality, reflective of the obesity in the DHS and the high proportion of female individuals. If you look at Mesa, the prevalence of the individual factors is different because the population's older, so there's more abnormal calcium, and the NT-proBNP and troponin levels are higher. CRP is lower because the BMI is a bit lower. Now, what we found when we looked at these tools is that each of these tests provided, in the DHS except CRP, provided independent and incremental risk information for the global cardiovascular disease outcome, after accounting for all of the traditional risk factors and also accounting for all of the other 4 tests. So what this tells us, number one, is that we get moderately robust risk prediction from each individual test, but that these tests are providing non-redundant insights into the underlying pathophysiology of cardiovascular disease, because after accounting for the other information, they're significant. This replicated in Mesa with generally similar adjusted hazards for future events. And in Mesa, with the larger number of endpoints, CRP actually made the cut, was also independently associated. Now, there are many ways one could put these data together in a very simplistic fashion. For actuarial risk assessment, we just created a global score that simply added up the number of abnormal biomarkers, abnormal EKG or the 3 biomarkers one had. About a third of the population in the DHS had no abnormalities, and they had basically no events over 10 years. And you can see that there's about a 40-fold gradient in risk across higher levels of this score. And the adjusted hazard across this is about 5. So you're definitely getting to adjusted hazards that move the needle in the office for these combination, what we call multimodality risk assessment tools. I think importantly, the subgroup data are really promising in that it performs the same in men and women across different ethnicities among younger individuals. And then I think the way this would largely be rolled out would be as in people that are perceived to be at lower risk on the basis of traditional risk factors, but who are interested in doing more, if you know, and would take a statin or take intensified blood pressure medicine if they were found to be at risk. And you can see that this performs very robustly with adjusted hazards, you know, up to 15 across the score in lower risk individuals. And that's where really I think this augmented risk assessment would be most useful. But that is the opposite of precision medicine by lumping all these endpoints together. If you were to do something like this with biomarkers, yes, you could get clearly augmented actuarial risk prediction, but that doesn't move us towards deciding how we're going to treat patient A who's at high risk different from patient B. But in point of fact, there's a lot of unique information from these different tests. Each of the different tests variably predicts different outcomes. We've talked about some of this already. NT-proBNP, powerful marker of global disease, coronary disease, and obviously very robust for heart failure. Troponin is a particularly robust for heart failure and less so for coronary disease. CRP in our studies was strongest for heart failure. And then you have coronary calcium, which has little heart failure prediction, but really remarkable coronary disease prediction. EKG LVH, really global cardiovascular disease and heart failure. So it's not exactly precision medicine, but maybe what one could do when you identify people at high risk is be able to characterize with a biomarker profile, for example, what exactly people are at increased risk for. Somebody at risk for AFib, for example, might be targeted for more frequent Apple Watch monitoring, weight reduction, exercise, and targeted screening so that we didn't miss the opportunity for stroke prevention. Somebody at higher actuarial risk for coronary disease who sort of know what to do, targeting lipid-lowering medicines. But then the group we may identify with NT-proBNP, EKG, and troponin, people at specifically high risk for heart failure who may not have high calcium scores. Those individuals may be targeted for, in addition to lower, progressively lower blood pressure goals, other therapies that may prevent heart failure, for example, SGLT2 inhibitors down the line. And so it's not exactly precision medicine, is it? It's not where I'd hoped we'd be in 2023, but if you can match the biomarker profile with a specific endpoint of interest, it may be a step in the direction towards intelligently targeting therapy and capitalizing on these relatively low-cost tests. A couple of other that there is hope that machine learning and artificial intelligence may help to, particularly with the combinations of these different profiles. This is an example of a study that was done by members of our group in some of the NIH cohort studies. I won't go through all the details, but it's reassuring. I'll skip to the next slide to see that the AI tools detected at the very top of the list in terms of the most information, NT-proB and high sensitivity troponin in Black adults, and in white adults, NT-proBNP is still first and troponin a little bit later. This also factors in social determinants of health that end up emerging as more powerful predictors of health in non-white populations in the US, as I'm sure is the case everywhere. But you might be able to use these tools to leverage social determinants together with some of these objective markers. Now, how are we going to use these tests clinically? There's not much implementation science yet. One of my favorite studies was done by an Irish group, by Ian McDonald. They did a study called Stop Heart Failure because I think it's relevant from a population health approach. And what they did is they took individuals in primary care and they measured BNP levels in primary care. They randomized one group to blinded measurements where they measured the level and did nothing. And in the other group, they did an intervention that was based on the BNP measurement. In the BNP measured group, They performed risk assessment based on the BNP and risk coaching for those that was informed by the BNP level. But I think most relevant from a population health standpoint is what they did for the individuals that had a BNP that was elevated was co-manage the patient between primary care and cardiology and perform additional testing with an echo. So they used the biomarker to inform prevention discussions, but also to guide referral decisions and shared management. And it's a pilot study. It's not a clinical study. The endpoint was a composite of echo measures of systolic and diastolic dysfunction and clinical heart failure. And they found that this composite was reduced by about 40%, which was highly significant. And if you look at the group that was really actionable, the group with a BNP above 50, both the relative and obviously the absolute risk reduction was particularly robust. I mentioned SPRINT. We actually performed biomarker measurements in SPRINT with troponin and NT-proBNP to try to decide whether these biomarkers might help us to guide which of the patients we see in the office we should be pushing for stronger blood pressure targets. And we did not find, despite our hypotheses, any qualitative interactions. The relative risk reduction from intensive blood pressure control was the same if troponin was high or low, BNP was high or low, or even if you had both biomarkers elevated. But what does differ, because these are powerful risk predictors, is the absolute risk reduction and the NNT. So if you look at individuals, for example, that have both troponin and NT-proBNP abnormal, the absolute reduction in death or heart failure is 8% over 5 years, and the number needed to treat is 13. Whereas if you had none of these biomarkers elevated, the absolute risk reduction is under 2 and the NNT is 58. So if you're in a resource constrained environment, you may make the case that we're going to target these, these biomarkers to those individuals at the highest risk. Even potentially more promising is the concept that we can use them to make decisions, not just about the intensity of blood pressure lowering, but who to treat. Remember, in the US, at least, guidelines, we're now recommending drug therapy based on the pooled cohort equations. But the biomarkers work so much better than the pooled cohort equations to predict risk. So we asked the question, could we embed the biomarkers into that decision, treat, not treat, for those with stage 1 hypertension? And this was done using data across multiple of the NIH cohorts. And what we observed in the group that was not recommended for blood pressure medication based on 10-year risk less than 10%, if they had abnormal troponin or BNP, the number needed to treat was markedly lower than the group that had normal troponins. And in fact, the NNT was lower than the group currently recommended for antihypertensive medications who had normal troponin levels. So, and this is modeled based on what we meta-analyses of blood pressure lowering. And in this group that has stage 1 or stage 2 hypertension with abnormal biomarkers has an NNT that's the same as stage 2 hypertension or stage 3 hypertension, rather, 160 over 100. So you may rather than simply using the pooled cohort equations, a simple biomarker measurement may help to identify which individuals with stage 1 hypertension are the most efficient to treat to prevent long-term complications. Same concept has been, in the interest of time, I'll skip this. The same concept has been put forth for PCSK9 inhibitors, and we've done work with SGLT2 inhibitors, demonstrating that using these tools, the biomarkers and EKG LVH, we can stratify the absolute benefit from initiating these drugs or at least modeling the initiation of these drugs for heart failure prevention. And what we can do in a resource constrained environment is identify about 10% of individuals that have multiple abnormalities, and that group has 40% of the events. And so if we can't afford widespread SGLT2 inhibitors in some of our systems for heart failure prevention, if we target it on the basis of biomarkers, we may prevent a substantial proportion of events and treat a much smaller number of individuals. So I'll conclude. Disease-specific, causal, and modifiable cardiac biomarkers have unfortunately proved elusive. These qualitative go, no-go biomarkers like the EKG for STEMI are rarely seen, and when we've seen them, they haven't replicated. But what we do see, though, is markers of existing subclinical disease, coronary calcium for atherosclerosis, NT-proBNP, EKG LVH, high sensitivity troponin, enhance actuarial risk assessment, and also provide outcome-specific risk assessment, for example, for heart failure. And this enhanced risk assessment that's more accurate, that's outcome-specific, I believe can be leveraged to move towards this precision-like prevention and population health management. That may be as good as we can do for the next few years. And that, though, may help us to individualize treatment choices regarding blood pressure, lipids, diabetes, medications, to triage, to enhance prevention clinical care models, whether those be virtual or actual. And what I didn't talk about is it can be really powerful for clinical trial enrichment to reduce sample size and lower costs. So thanks to you all for listening, and to the many collaborators and trainees who did this work.
We'd like to invite questions from the audience and online. I might invite Dr. Liu maybe to make the first comments, obviously as an expert in the field.
Yeah, so James, is just a fantastic talk. Really actually not only kind of put the field in perspective, but actually brought hope, for us to work in biomarkers. But I think it really underscores the importance of kind of thoughtful analysis of these large databases, right? I think it just illustrates so importantly in terms of the ability to actually provide insight, when actually do these and then replicate across the different studies. And at the same time, it really actually begin to help us to address the issue that we face, in that, patients faced with a huge multitude of potential options, and quite often say, do I really actually need all this, right? Yeah. And this, you must be able to do better for me, right? From that point of view. And this is actually kind of the path for us to get there. But I wondered about, I guess from a couple, it's a philosophical or how to go forward basis. And that is that in cardiovascular, we're blessed with the fact that, we have large populations. We can do these, very large studies and have a single outcome. And then we try to apply this to everybody, right? And so in cancer, however, they actually embedded the biomarkers into the study so that in the end, you can actually begin to do this type of analysis. But we seem to try to avoid that, or certainly our private sector partners, try to avoid that. And then the other thing is, what level of evidence? Because quite often, this type of information is super helpful, even today, in terms of patients sitting in front of you. But, many of my colleagues will say, there's not enough evidence, at the same time, in heart failure, for example, we just pile on all the evidence-based medications for patients. And a lot of patients says, I can't take all this, right? And so what would it take, for I guess the community to move forward so that one can actually think about, doing this for individual patients rather than, the traditional guideline, just, sort of pile on.
No, it's a great question. It's funny, right? Because the guidelines have no problem recommending that everybody get a pooled cohort equation, or the AFib guidelines saying everybody, great comments, by the way, Dr. Liu, but, gets a CHA2 VAS score. So the guidelines have no problem recommending diagnostic or risk assessment tools that are not evidence-based and haven't been subjected to randomized controlled trials. But if you say, I recommend that you consider measuring this biomarker or coronary calcium, many people think that you need an RCT to demonstrate. And I think that it is going to be really difficult to demonstrate clinical risk reduction from a test, right? Because that test, the sample size is only a small proportion of the people tested are actionable, and the sample size requirements are massive. And then you don't control the downstream response. You might treat the patient fundamentally different than I do, and I think that's too high a bar. And so, and I think that fundamentally, the argument for targeting therapies to higher risk individuals is rock solid and embedded, and if it's cost effective to implement some of these, that's and you can model at least that it doesn't drive costs up and lead to secondary testing, that I think it's, we probably know enough to start implementing some of these now, because I don't think there ever will be the kind of randomized controlled trials for these kind of testing strategies. The question about embedding, I think you're absolutely right. The drug companies have a big disincentive to embed they're typically done, the biomarker studies, but the drug companies have a big disincentive to lowering their market share. But that may be changing. I hope, given what's happening in therapeutics where these therapies are coming out so expensive, they're not actually getting used. And so, to justify the high cost of the medications, maybe there will be some appetite for embedding at least these actuarial tools so they can identify who's going to have the largest benefit to justify these exorbitant costs for what's going to happen for LP(a) inhibitors and who's going to be recommended for gene editing for PCSK9. How are you going to make those decisions, right? Yeah.
We're going to jump to the chat. So we have Dr. Mike Burke, who ran our cardiac surgery ICU for many years. Question on the chat is Dallas Heart Study implications and high sensitivity troponin. How do you approach this message with the changing and increasingly sensitive troponin assays? How do you approach this message with the changing and increasingly sensitive, high sensitivity troponin assays?
Yeah, so we've been, I think we probably are as sensitive as we need to be with troponin at this point. I don't know that there's going to be huge advantages to there are single molecule troponin assays that are out there. But I think, and I don't know that it will materially change the narrative about this chronic injury that we're measuring. I think the question of how to handle troponin in the ICU, because the question comes from somebody that runs an ICU, that's a mess. And that could be a whole separate talk. But the application of high sensitivity troponins in the ED and hospital setting is a mixed bag. Clearly, because frankly, because we don't know what to do with the information when we detect acute non-ischemic myocardial injury is ubiquitous and detected much more commonly now with high sensitivity assays. And the more sensitive the assay, the more you detect it. And the challenge just is we don't have the tools that we need to distinguish ischemic from non-ischemic acute injury, and we don't know much at all about how to handle those patients, and it creates all kinds of angst from our internal medicine colleagues, and for us with our surgical colleagues that aren't cardiac surgeons. It's even complicated post cardiac surgery.
Yeah, absolutely. The vision trial, it speaks to that. I have a comment from Dr. Ruel. James, thank you for a great talk. I, like many others, learned a lot. You talked about coronary calcium as being very predictive for clinical CAD. What about the paradox of stable calcified versus soft non-calcified plaque? As you know well, results of observational studies on exercise are rather disturbing. More CAC yet better longevity in people who exercise. Mix of causal and selection bias maybe. Is your precise personalized exercise recommendation different in someone who has significant coronary calcium or say other detrimental biomarkers versus not? Thanks again.
Great question. So let me separate that out. So calcium is not pathogenic, in terms of plaque rupture. If anything, it's probably protective. It is true in younger individuals that one can have non-calcified plaque, but even coronary calcium is a crude measurement. These are all, I didn't talk about this, but even the best biomarkers are, I should have mentioned this, but the reason they don't work for precision medicine is because they're too promiscuous. The factors that influence troponin and BNP biomarkers measured in the heart are so varied, including non-cardiac factors like body weight changes and kidney function changes. They may have dominant effects and changes, and so they just don't work well enough to drive specific decisions. Because if you can't even monitoring these for treatment response is confusing, because a therapy that like intensive blood pressure lowering that raises GFR, lowers GFR transiently, may make the troponin go up, even though the intensive blood pressure lowering is beneficial for the heart. The calcium is a crude measure. And so the way I think of calcium is just as a crude measure of total atherosclerosis burden. And I don't even think about the pathophysiology of the calcium itself, which is largely irrelevant. And the proportion of calcified plaque in most individuals, but not everybody, is generally proportional to the proportion of non-calcified plaque. So so people who have no calcified plaque generally have very low rates of events, not because the calcium and it doesn't, but from a pathophysiology standpoint, it doesn't mean much. The exercise question is really interesting because we've seen, and Mark's participated in these discussions at circulation. I think it's a true finding that it's the is it Philippides phenomenon? I think it's the marathoner who drops dead at the end of the marathon. But this concept that that people who train heavily may have excessive calcium relative to their risk factor burden. And, people who work in this space think it's sort of shear forces and maybe a different non-atherosclerotic mechanism. Although, honestly, when they have CTA does show atherosclerosis in most of these segments, given the beneficial effects of exercise, the fitness tends to modify any risk associated with the calcium. And there's no data at all that I'm aware of that shows that these individuals who have exercise, these, potentially training related coronary calcium are at particularly high risk for events. So it has no implications for me in terms of telling people to exercise less. If somebody had a calcium score of 2000, I might, and they were running competitively, I would probably evaluate that for safety. But for the small amounts of coronary calcium we tend to see in athletes, I tend to treat it the same way I do non-athletes, candidly, and put them on statin therapy if they'll take it. But the other biomarkers also, exercise is even more complicated because exercise may, if you measure troponin after exercise, it may go up. That's well known. The mechanisms there are probably different. It's probably released from a cytosolic pool and not a membrane-bound pool, and the results are confusing and conflicting. Generally, most individuals who have exercise-induced release in troponin do very well, although some of the larger studies do suggest that in older individuals, the people who have very large increases, particularly with sort of moderate levels of activity, may have higher rates of cardiovascular disease. That field is pretty confusing.
Okay. So super interesting. I hear pagers going off, and we're moving on, I think, to your next session. But I'll give the last word to Dr. Kwan Chan, one of our ECHO leaders in the building. All respect to Dr. Burke, who cycled back with another question. But Dr. Kwan Chan's question is: malignant hypertension is more impactful in the Black, raises the importance of genotype. Any data on this?
Great question. We're working on that. It's hugely important. I mean, we're interested. We think we think it's more likely social determinants of health driving this than genotype, but it's plausible. There are several genotypes that are more common in people of West African ancestry, including epithelial sodium channel, natriuretic peptide genotypes that potentially could be small factors, but the dominant factor is going to be the social factors that lead to higher hypertension burden.
Okay. Well, thank you so much, Dr. Lemos. That was amazing. Appreciate everyone for their engagement and for their attendance. Wish you all a wonderful day.
Thanks.